Today we have Dr. Copeland-Halperin joining us. If you could all mute yourself, please. Thank you. He is a physician at the Zucker School of Medicine at Hofstra, Northwell, where he serves as the Director of Cardio-Oncology and for the Northwell Health system. Today he will be speaking about ovarian cancer and the important cardiovascular side effects. As a cardio-oncologist, he works with patients and their oncologists to enable them to receive the most effective treatments for their cancer as safely as possible in order to optimize their health and overall outcomes. He will cover a basic introduction into the emerging field of cardio-oncology and provide some practical tips and advice regarding this. So without further ado, I will hand it over. And if you have any questions, please put it into the chat and we will have a Q&A at the end. Thank you.
Thank you, Carly, for that nice introduction. I'm just delighted to be here. Let me get these slides up here. All right, so yeah, thank you again for having me. I have been looking forward to this for a long time, and would also like to thank Susan Engel, who connected me to you guys for this opportunity to speak with you today about my field, cardio-oncology. Right. So today I'm going to try and cover the following things. I'm going to tell you a little bit about what cardio-oncology is and how I see our role in the care team. I'm going to talk about what's becoming increasingly apparent is a connection between cancer and the heart, and that heart disease and cancer have a bidirectional relationship. I'll talk about some specific therapeutics that are of relevance to patients with ovarian cancer, and the cardiovascular side effects that have been associated with those. And then also share some resources and additional ways that you can learn about cardio-oncology and again, tips for your health. So I am a cardiologist, not an oncologist. I trained in cardiovascular disease, but my practice is focused mainly on cancer patients and cancer survivors. And the idea is to try to manage potential side effects on the heart from cancer treatments or during the cancer care, and also to prevent those side effects from occurring. And the way we do that is by screening and also assessment and treatment of any modifiable risk factors, which I'll talk more about as we go on. And I like this field because it's a collaborative field. We work hand in hand with the oncologists and to try and customize the treatments and personalize them to the individual case. They will tell me what they understand about the tumor markers and the disease biology, that what treatment options are available. And then I provide the other side of the coin and talk about the potential risks to the heart and what the options would be if those side effects unfortunately occur. And so we can work together to try and come up with the best approach for an individual. And so cardio-oncology, basically, I see it as taking place in these three phases. We do assessments prior to beginning cancer treatment to try to assess what is the risk of this potential therapy and for this potential patient, and what can we do to reduce that. We do monitoring during cancer treatment, and there are some cancer treatments like that are used for breast cancer, for example, where there is recommended cardiology screening by EKG and echocardiogram that sort of must be done, and we help to coordinate that, of course, to help manage any cardiovascular issues that may arise. And then the third phase of this is after cancer treatment in the survivorship period, which is becoming increasingly important as cancer patients are living longer than ever before. And so these data are from the National Cancer Institute. The number of cancer survivors in the United States is increasing significantly. And in the past 2 decades, there's really been almost an epidemic related to this success of cancer treatment, because cancer patients are living longer and longer. And what we're learning is that even though they have beat cancer, there is an increased risk of heart disease in cancer survivors relative to the general population. And so cardio-oncology is becoming important for this reason, as these patients, increasingly need to seek cardiology care. And as we recognize this as an effect of the treatments that we give. And cancer patients of every site are known to have an increased risk of heart disease. These are data from SEER Medicare. Basically, what you see here are different cancer sites, and these are standardized mortality ratios, which is the ratio of death from heart disease for these cancer sites relative to the background population that did not have cancer. And this study included over 13 million patients from SEER Medicare, but this has been shown in other contexts as well. And as you can see here, from the time of diagnosis forward, there is an increased risk of heart disease, of death from heart disease, and for cancers of every site. And is also this biphasic pattern here, where the risk is highest within the first year after diagnosis, and then rises again about 5 years later. And that's the so-called, survivorship period. And it's also interesting here that endometrial cancer seems to have a higher risk than other cancers of other sites. Now, why might that be? Well, one of the positive explanations is shared risk factors. That is, patients with endometrial cancer, obesity is a risk factor for endometrial cancer, and it's also a risk factor for heart disease. Sedentary lifestyle is a risk factor for both. And diabetes as well is a risk factor for endometrial cancer and heart disease. So that's part of the reason that they think for this observation. What about ovarian cancer? So ovarian cancer was not displayed on the previous chart because the risk of heart disease was lower than for the other cancer sites. The data that we have specific to ovarian cancer come from a similar database, but in the UK. And this was a study looking at patients who had ovarian cancer at the NHS who were being treated, and they looked at the incidence for various cardiac complications relative to the background population. And as you can see, the risk is higher than the general population. But it's interesting that certain conditions seem to be more common. Embolism, like blood clots, 6 times higher relative to things like arrhythmia, which was 1.13. That was the hazard. So that's really not that much more relative to a patient without ovarian cancer. And as you can see, these are the confidence intervals here, which cross 1, which means that it basically could even be equivalent. We don't really have enough information to say one way or the other. So what are the incidents of blood clots? These are like DVTs or pulmonary embolism. It seems to be an important problem in ovarian cancer. This is another study looking at the incidence of DVT in patients by cancer site. And as you can see here, ovarian cancer patients had a risk of 11% was the incidence of a new DVT. So that seems to be a significant concern, and it has relevance to some of the treatments that we're going to discuss today. So what are the mechanisms of heart disease or cardiotoxicity from cancer treatments? Basically has these 3 flavors. There's the shared risk factors that patients with underlying heart disease are, of course, at higher risk than those who don't have any history of heart disease. There's effects of the cancer treatments themselves, like radiation and certain chemotherapies, which we know can cause damage to the heart and blood vessels. But there's also this third piece. The cancer itself seems to increase the risk. And this is what I think is most interesting. There's commonality between the biology of cancer and heart disease that I think helps to explain part of this and is really where the future is headed. So we've talked about the increased risk of heart disease in patients with cancer. This is the other side of the coin. In patients with heart disease, have a higher risk of cancer. These are patients with heart failure, and compared to the background population of the same age, looking at the incidence of cancers of any kind. And as you can see, for patients of all three tertiles of age, that is patients under 60, between 60 and 70, and then 70 and above, relative to their peers of the same age without heart disease, they have a higher incidence of cancer. And what's even more striking is if you look at the patients who are age 60 to 70 with heart disease, their risk of cancer is even higher than patients who are a decade older. And this has been shown in numerous other population studies as well. Here's another observation which is interesting. This is from an animal study that I think was a very important paper that came out of the Mass General Hospital a few years ago. They have an animal model of mice where they can study heart failure, and it basically is a pressure and volume induced remodeling of the heart muscle. And they compared this model of heart failure in two contexts. They had tumors that mice that had tumors of the breast and of the lung, and they compared them to controls who did not have this heart failure model. And what they found was that the mice who had the tumors, but then were subjected to this hypertensive cardiomyopathy, which they do by something called an aortic cross clamp. And it's sort of the same thing as causing very high blood pressure effects on the heart, or, for many years, or a narrowing of the heart valve, which then leads over time to stretching and dysfunction of the heart. It mimics that. And what they found is that the mice that had this hypertensive state, the number of tumors increased, that is, they had more number of metastases, and the average size of those tumors was larger than those in the control group, which is fascinating. And what they did as another step, which is not shown here, is what they checked the blood of these mice, and they saw that there were increased levels of tumor growth factors in the mice with heart disease. So there's something about the heart disease which is promoting tumor growth in both the laboratory and in the animal models. This is another observation which illustrates this important connection. There's something called clonal hematopoiesis of indeterminate potential. So what does this mean? As we get older, there are mutations that occur sporadically with age that are found in our blood cells in our bone marrow, and they're just encountered in the population, and they're quite common. And these mutations are present in perhaps 20% of people who are over age 70. And these mutations are associated with a very small risk of transformation to leukemia or lymphoma, but nothing to really get worried about. The risk is like less than 1% of that happening per year if you happen to have one of these mutations. But what they found was those who have these mutations, which again are quite common, the risk of heart disease, heart attacks, strokes, was 40% higher. And that's independent of traditional risk factors like smoking or high blood pressure or diabetes. So these mutations that are associated with cancer in a small degree are associated with a significant, almost twofold increase of heart disease. And so these are just some of the observations which have led us to this understanding of this bidirectionality between cancer and heart disease, one that's mediated by shared risk factors like smoking, of course, and sedentary lifestyle, but also common disease mechanisms, promotion of these tumor growth factors as a function of remodeling of the heart. Genetics, of course, and shared environmental factors play a role. And so today, when we think about patients with cardiovascular disease and cancer, I'm thinking about it much more than just reducing the cardiac side effects. I'm thinking that, the patients with cancer who have these heart disease risk factors might potentially in the future be found to have improved cancer outcomes if we can control their underlying heart disease and treat it better. That's sort of the dream here. And I think ultimately, as science advances, this is the way that we're going to be thinking about it, that it's a two-way street. And this is something else that is hot off the press, just came out in one of the leading cardiology journals 2 weeks ago in the beginning of July, that was fascinating. They found that CA-125, which I'm sure you all are familiar with, was elevated in patients with heart failure, and that it was associated with increased heart failure events. And this was taken from a large clinical trial of one of the new drugs that we are testing for heart failure. And this notion that the CA-125 was a predictor of cardiovascular events like heart failure, patients getting filled with fluid and admitted to the hospital for that, or more short of breath, or having worse outcomes from their heart disease, was something that I had never heard of before. But it turns out that this has actually been known for years, that CA-125 is a marker of heart failure, and it might even be useful to measure in our patients with heart failure independent of cancer. So carbohydrate antigen 125, or cancer antigen 125, it's a protein that's made on the epithelial cells of surfaces of the mesoderm, which are the tissues that line the organs in the body, like the pleural sacs that encase the lungs, and the pericardium, which is the sac that lines the heart, and in the abdomen, the peritoneum. And it is increased in states of fluid overload when those surfaces get stretched out, like from accumulation of fluid or ascites. The CA-125 gets synthesized and increased. And it's also been shown to be involved in the immune response and repair mechanisms, and is well established as a marker for ovarian cancer. And they know that levels correlate very well with volume overload and congestion. And they've known this in heart failure actually for 2 decades now. And it has been established not just in this most recent trial, but in other studies as well, as an independent predictor of outcomes in patients with heart failure. But the levels that are in ovarian cancer are actually much higher than we typically would see in a patient with heart failure. As you can see from this study, the level that they used as the cutoff was 35, which is really not that high relative to the levels that can be seen in active ovarian cancer. So, this isn't something that's really ready for prime time. This is, just recent research that's hasn't really made its way into clinical practice. But I think it's just very interesting to think about. And it was something that, as a cardiologist, I hadn't even heard about until just a few weeks ago. So these are among the specific cancer treatments that have a particularly important incidence of cardiac toxicity. And the notorious ones are things like anthracyclines, which is also called doxorubicin or adriamycin or epirubicin. And these are still used as the backbone of treatment for breast cancers and many hematologic malignancies like lymphoma. But they're also used in ovarian cancer. And typically what's given in ovarian cancer is a liposomal form of adriamycin called Doxil. Doxil is much safer than the traditional form of anthracyclines, but it still is something that carries a dose-dependent risk of weakening the heart muscle. And often patients are referred to me for monitoring and management of that, especially if they have a history of heart disease. The oncologists often want them to see a cardiologist before they administer that treatment. Herceptin or trastuzumab is a targeted therapy. It's an antibody that is used widely in breast cancer and has also been associated with cardiac toxicity. And they recommend monitoring of this every 3 months, actually, on the package insert by getting a heart echo. So that's also another important one. There are treatment regimens used for gastric cancers like FOLFOX or Xeloda, which have been associated with chest pain syndromes. And we can treat that and enable the patients to continue the treatment safely without chest pain. There are also newer targeted therapies, these tyrosine kinase inhibitors, or these oral therapies that are being used more and more in many different types of cancers. And they're like daily oral medications instead of infusions. Some of them are also given IV, but they're different than traditional cytotoxic chemotherapy, that they target specific cell markers that are implicated in tumor growth. And many of these have been found to have specific cardiac side effects, commonly arrhythmia or high blood pressure. And then there's the field of cancer immunotherapy, which is absolutely exploded. We're now 50% of all patients with cancer in the United States, 50% of cancer patients are eligible for some form of immunotherapy. And this is also associated with, fortunately, very rare but important cardiac side effects. And radiation, which has been a mainstay of cancer treatment for decades, and fortunately, we've learned to give it a lot safer now than we used to do in the 80s when they used to give mantle field radiation. But there's still many patients alive today because of that treatment, and they have a high risk of disease of the heart valves and arteries as a result of that treatment that they received. So I wanted to talk a little bit about some of the specific treatments related to ovarian cancer, the ones that are used commonly, and the cardiac implications of these. So Avastin, as many of you know all too well, is associated with high blood pressure and can also cause damage to the kidneys. There's also a risk of blood clots, but importantly, also some concerns about bleeding, which make it a little bit difficult to treat blood clots. So Avastin is a humanized monoclonal antibody that targets the vascular endothelial growth factor receptor, which is a marker that is involved in the formation of blood vessels. And tumors need a food supply to grow, and that food supply is blood. So many cancer types, and particularly ovarian cancer, have a high level of expression of vascular endothelial growth factor on their surfaces of the cells, and that enables them to promote blood vessel formation, and the tumors grow based on that. And they've found that if you inhibit that factor, that you can reduce the tumor growth and eliminate the cancer and improve outcomes. But as you can imagine, this growth factor for blood vessels has salutary effects as well, and it's related to the homeostasis of the blood vessels linings and the way that blood pressure is regulated. And so high blood pressure was seen very early. Avastin was FDA approved in 2004, and very early on it was recognized that high blood pressure was an important problem. These are some of the clinical studies of Avastin in ovarian cancer, just to give you a sense of how common this problem is. This is all-grade hypertension, that is any kind of new onset of high blood pressure that required treatment. As you can see, in Avastin, in these trials, new onset high blood pressure might occur in up to 40% of patients, which is incredibly high. And this high blood pressure tends to occur relatively early on within the first few months of treatment, but it can occur later as well. And this can happen in people who never had high blood pressure before, and now all of a sudden their blood pressure is 180 or 200 or higher. And high blood pressure, as a cardiologist, to me is no big deal. That's even an internist can treat high blood pressure. But what happens is high blood pressure is not really something that you feel. And so you will show up for your treatment and the pressure is high, and then you don't get the treatment because they won't administer it if the blood pressure is over a certain threshold. And now all of a sudden you're not able to get the cancer treatments that you need to beat the cancer. And this compounds the problem. So often what we do in this case is we have to start treatment for the high blood pressure with medicines, but we have a lot of options for that. There's so many different choices that we're usually able to get it under control. And we get the blood pressure regulated, and then the patients are able to continue, in many cases, the Avastin safely with the blood pressure under control without causing further organ damage or damage to the heart. And then if they complete the course of treatment, often they'll no longer need those blood pressure medicines, as it can be reversed when they're no longer getting the Avastin. Not always, but most of the time, we're able to peel some of those medications off after the patient's treatment is discontinued. But this is an important issue, again, occurring maybe in 40% of patients. And there are specific approaches that we take that are preferred in terms of the kinds of medicines that we think might work better. And so sometimes these nuances, we can be helpful and enable, patients to have a better outcome. Next, I'll talk about PARP inhibitors. These, as many of you know, are oral medications that are used as adjunctive therapy in ovarian cancer for patients with relapse disease. And these are the three currently approved ones. There may be one more now, but these are the ones that I think are the most commonly seen. And they're often used in conjunction with Avastin. They're also used in some prostate and breast cancers. And that's where some of our data on the side effect incidence comes from. These generally are pretty safe from the cardiac point of view, but there does seem to be a signal for increased risk of blood clots relative to placebo, which I think just bears, some caution and observation and some thought, especially in patients who may be at increased risk for this, like patients with ovarian cancer who have received platinum therapy or vascular endothelial growth factor inhibitors. So those patients who are receiving both, some consideration should be given to the risk of blood clots, I think, and perhaps a discussion should be had about using prophylaxis to prevent that event. Again, not so much even because of the morbidity of a blood clot, which, was often not a fatal event, but the idea that if this happens, it disrupts the cancer treatment. Patients wind up in the hospital and they miss treatments, and then that adversely affects the outcome. Why? So the way that I do this is an integrated model. Depending on what the patient's cancer is, their underlying risk factors, their history, their values, preferences, lifestyle, and the types of treatments they're going to be receiving, we design a personalized approach. And this approach integrates the pre-treatment risk assessment, use of imaging like ultrasounds of the heart to monitor for subtle changes in heart function that may become apparent before the patient has symptoms and enable us to tailor the therapy or to intervene and potentially prevent that toxicity from happening. There are biomarkers that are used in a complement to this, and these are markers sort of like CA-125, except they're for the heart. They're markers of microscopic injury to the heart cells, things called a troponin, which is used to diagnose heart attacks, but it measures microscopic injury to heart cells, and something called the BNP, which is brain natriuretic peptide, which is secreted in response to fluid overload and stretching of the heart. And we use that in patients with heart failure. And so the idea is to use these blood markers in conjunction with things like the echo imaging and the physical exam and what the patient tells you to try and detect problems before they cause symptoms and before there becomes irreversible damage to the heart, because we have studies that show that we can intervene in some cases, particularly in the breast cancer setting, and prevent those toxicities from occurring with medications and with optimal control of risk factors. And this is done in collaboration with the patient's oncologist. We discuss these interventions and try to personalize the care. And I also just wanted to share this with you. This is some research that I'm particularly proud of that I did with my mentor, Anthony Yu, when I was at Memorial Sloan Kettering. This was a study of patients who had breast cancer who were receiving Herceptin, which is known to cause weakening of the heart muscle in otherwise healthy young patients oftentimes. And the package insert for Herceptin recommends monitoring the heart with an echocardiogram, a sonogram, every 3 months. And if the function of the heart decreases by a certain amount, you stop the treatment and then you hold it and you repeat the echo. And if the heart function gets better, then you can resume. And this is what was being done for many years. And so we looked at the series of patients at Sloan Kettering. There are 1,400 patients who had received this treatment. And we compared those who'd had a treatment interruption for whatever reason to those who were able to continue the treatment without any interruption. And what we found was that the increase in cancer relapse and mortality was much higher in those who had treatment interruptions relative to the continuous group. That is, treatment interruptions increase the risk of disease recurrence and reduce survival. And you'd think that, okay, sure, if the patient doesn't get the treatment, they wouldn't have as good an outcome or as good a response. It makes intuitive sense. But these treatment interruptions, if they can be prevented by early intervention, then we might have a chance to improve the cancer outcomes as well, not just the heart, treating the heart, but when we treat the heart, we might actually enable the patient to have improved cancer outcomes and survival. And this is the concept which is now beginning to shape our practice in cardio-oncology, whereas if we do see changes in the heart function, it doesn't necessarily mean the patient has to stop treatment. We can make an assessment, get the heart treated, and enable them to continue the treatment safely. So what can you do? So I think a lot of this is common sense, but I would encourage all patients with cancer to know their cardiac risk factors at the beginning. So they should find out what their cholesterol numbers are, your blood pressure, whether you have diabetes, because optimizing these risk factors, both through lifestyle interventions and possibly medication, and of course, diet and lifestyle and medications must go hand in hand. You can't do one without the other, can have important implications for the risk of heart toxicity during your cancer treatment. And it's so easy to overlook this at the beginning of treatment when you've got so many other appointments to go to, port placements, surgeons, radiations, you're meeting with so many different people, and that often these basic, easy, low-hanging fruit to reduce the risk gets overlooked. And I think it's unfortunate. Of course, you can't control everything. It's not your fault that you've got cancer, nothing that you did, and you can't do anything about that. You need to get these treatments, which may have heart risks. You need to get the treatments that you need to live. But anything that you can control, I encourage people to do. Of course, don't smoke. To stay active, physical activity is very important, both for heart disease risk and overall well-being. And if we can do things like treat the high blood pressure or get the cholesterol under control, that's something we can just do easily, and it's within our power. And so I think that that's the kind of attitude that that I encourage. And I would encourage you all to ask about what could be done to reduce the cardiac risk of your cancer treatments. And of course, talking with others and community as well. So cardio-oncology is a new field, but it's becoming increasingly prevalent to have cardio-oncologists at your cancer center. And so this is a nice website that you might want to jot down. This is the International Cardio-Oncology Society, and there are chapters actually all over the world. There's people doing cardio-oncology in Poland, in China, in Brazil, and in Europe, and all over the United States. And so they have lists of different cardio-oncology centers. So depending on where you live, you can find out if there's anybody around there with training and expertise in this area. And they also have information about cardiac risks for different treatments and to help you become more informed. And this is my practice. I see patients here in Manhattan at Lenox Hill, Greenwich Village, which is downtown, and also on Long Island at the Northwell Health Cancer Center, which is near Long Island Jewish Hospital, which is right near Queens and Great Neck. And, if there's any questions, I can be very happy to meet with you, and I can do telehealth visits as well. I very often work with patients who have cardiologists, but that maybe just aren't as familiar with these things. And sometimes there's certain questions that arise. And so, we can meet by telehealth and try to be of help that way. And again, collaborate with your doctors. And that's it. Thank you very much for listening to me, and look forward to the discussion.
Thank you so much. This was amazing.